Thank you for the privilege of presenting today. Why, you may be asking, is a breast surgical oncologist talking about radiologic topic? Well, a little background on how I became a physician. In the 1960s, I went to a very liberal arts college just north of Manhattan, Sarah Lawrence College, which was a hotbed of social activism. We did sit-ins in the administration building, protested the war, insisted on admission policies that were blinded to ability to pay. And I went door to door in East Harlem canvassing amputees to determine how many were able to walk on their prosthetic limbs, 8%. My senior year, a report was issued by the New York Commission of Health, Commissioner Mary McLaughlin, with a devastating indictment of public health stated here. And my determination to become a physician was born of a strong belief that public health in this country could do better. Throughout my more than 4-decade career, I've always done what I could to further my original public health goals. I was for many years an advisor to the Delaware Division of Health and Social Services. I've participated in innumerable public health task forces and committees and have organized speakers' bureaus on topics as diverse as infant mortality reduction and HIV transmission. So the topic of breast cancer screening is not only of interest to me because I'm a surgeon, but because cancer screening programs are a key public health component. You are aware that in May of 2023, the American College of Radiology updated their public health screening guidelines. And this table summarizes the salient points. Note particularly that MRI is recommended in addition to mammography for many categories of women, including all women with lifetime risk, 20% or greater, all women diagnosed with BCIS or breast cancer prior to age 50, all women with a personal history of breast cancer and heterogeneously dense or extremely dense breasts. MRI should be considered for women with atypia or LCIS. But before we consider the implication of these recommendations, let's review some principles of cancer screening in general. Importantly, health problems should be recognizable. There should be a latent or early asymptomatic period, natural history of the condition, including development from latent to declared disease, should be adequately understood. But most significantly, the cost of a screening program must not be so high that funds are expended on screening, which might otherwise be used for prevention or treatment of the disease. So let's look at the ways to estimate how many women might need screening under the new ACR guidelines. The American Cancer Society estimates that there are about 4 million breast cancer survivors in the US. 40% of them have heterogeneously dense breasts, and 8% have extremely dense breasts. An increasingly large proportion of survivors are now diagnosed prior to age 50, and about 150,000 patients each year are found to have atypia or LCIS in a core breast biopsy. Of the general population, 28 million have heterogeneously dense or extremely dense breasts, and with this many women falling into categories for which annual MRI has been recommended, it is clear that patient access and cost will be major barriers to widespread adoption of these excellent evidence-based guidelines for screening MRI in high-risk groups. There's no question that MRI is an excellent, sensitive, and specific breast screening tool, appropriate for women at increased risk. But access and cost are a problem. There are also many women for whom MRI may be contraindicated. Listed here Not only may a patient be over the 350 to 450 pound weight limit for an MRI table, but another patient may weigh only 260 pounds but be short and too wide for the unit. Contrast-enhanced mammography, or CEM, is an FDA-approved breast imaging modality which could provide an equally sensitive but more cost-effective alternative to MRI for high-risk screening, accessible to the majority of patients for whom MRI is contraindicated or unacceptable. CEM can be performed on the same machines currently used for digital mammography, with just a software upgrade. Excerpts from Massachusetts General Memorial Sloan, experts rather, from these institutions and MD Anderson Cancer Center and other highly respected institutions have supplied me with slides, quotes, and references for use in preparation of this presentation. Particular thanks to Connie Lehman of Mass General and Alina Weaver of MD Anderson, both radiologists who are nationally recognized in their field. CEM checks all 4 of these boxes for a high-risk screening modality. As I mentioned, it's performed on standard mammography unit with a software upgrade to permit dual energy imaging after IV contrast administration. Iodine-based contrast, like what's used for CT scans and IVPs, is given intravenously, and 2 minutes later, 2 images are required with different technical parameters. There's a high-energy image and a low-energy image. A recombined image is generated by digital processing software, which subtracts the low energy from the high energy image. MRI and contrast-enhanced mammography are both molecular imaging techniques. Something is injected by vein, and that material leaks out of the blood vessels of tumors and can be detected. Cancer blood vessels are different from normal tissue vessels. They're the product of tumor neoangiogenesis, and they're more abundant and leakier than vessels in normal tissue. IV contrast leaks out of tumor vessels into the tissue. The low energy and high energy acquisition images differ because high energy photons are absorbed by the iodine more than our low energy photons. So just as bone or a piece of metal shows as white on an X-ray, areas where more photons have been absorbed by iodine show white because more photons are being blocked in the high energy image. Images from Dr. Connie Lehman show the low energy acquisition here, which is difficult or impossible to see the cancer in, and the high energy acquisition after subtraction of the low energy, where the cancer is very cleanly identified. These studies and more are the reason that many believe contrast-enhanced mammography should replace MRI for high-risk breast screening, or at least be used for the majority of high-risk women. Transition standard digital mammography to CEM requires these elements. Any facility currently doing CT scans or MRIs will already have individuals who can start IVs and monitor and manage any reactions to contrast. These major companies already have CEM software and hardware. CEM, like MRI, requires contrast injection, but reactions are rare. Importantly, CEM has higher sensitivity and specificity than standard digital mammography, and similar sensitivity but improved specificity compared to breast MRI. And no additional mammogram is required for screening high-risk women when CEM is utilized. Annual mammography is recommended for high-risk women having screening MRI because MRI does not usually show low or sometimes intermediate grade ductal carcinoma in situ, which does show on mammography as clusters or ductal arrays of calcifications. The low energy acquisition of CEM is a standard digital mammogram. Sadly, even though CEM has been FDA approved since 2012, there's not been broad uptake of the modality. And this is why I am asking this audience to be local, regional, and national advocates for CEM for high-risk screening. The reasons for the lag in uptake have partially to do with the complexity of billing for the imaging. No, I know you can't read this. I know you don't care to read this. It's the detailed explanation of the fact that institutions can actually bill for CEM and describes the appropriate CPT billing codes. We need to dispel the urban myth that there is no CPT billing code for CEM. It's just that it's complicated. And AI-based cancer detection models are also in development for CEM. So looking at CEM and MRI head-to-head for high-risk screening, CEM is more accessible, or soon could be, lower cost, and has equal sensitivity and improved specificity versus MRI. Any modern mammogram machine can be upgraded to CEM capability. There are mammogram machines in every breast imaging facility. The cost to upgrade a mammogram machine to CEM is, at least as quoted to us at BB in March of this year, about $160,000, which includes software upgrade, education of radiologic technologists and radiologists, and the cost of hardware for injection and biopsy capability. The cost of a brand new mammogram machine, around $400,000. The cost of a brand new MRI machine is roughly $1 million per Tesla. So 1.5 Tesla, 1.5 million, and 3 Tesla, 3 million. In summary, CEM should replace MRI as the preferred contrast-enhanced breast imaging tool, given its diagnostic accuracy, access, lower cost, and patient preference. Understand, we are not talking here about using a modality for treatment planning in an individual diagnosed with cancer. MRI has an exquisitely important role in treatment planning for many patients diagnosed with DCIS or breast cancer. However, for the large number of women for whom high-risk breast screening is now recommended by the American College of Radiology, contrast-enhanced mammography is superior to MRI for all of the reasons that we've discussed this morning. Thank you. Thank you very much for your attention.